Now we are going to discuss another important topic, which is shock. A shock is a clinical syndrome characterized by systemic hypoperfusion caused by reduction in either cardiac output or in the effective circulating blood volume. So, in shock, there is hypotension, impaired tissue perfusion, and cellular hypoxia. Shock is the final common pathways for several potentially lethal clinical events, which are severe hemorrhages, extensive trauma, burns, large myocardial infarction, massive pulmonary embolism, microbial sepsis. Cell injury initially is reversible, but later on, with prolonged shock, it is irreversible. Now, in shock, there is hypoperfusion of the organs is because of decreased blood volume, which leads to decreased cardiac output and redistribution of blood. Hypoperfusion leads to decreased oxygen and nutrients supplied to the organs and tissue, and also decreased removal of waste products. Now, this is a sort of flow chart which showing how shock acts. First, there is hypoperfusion of the tissues leading to impaired tissue perfusion, which leads to cellular hypoxia. Now, cellular hypoxia is responsible for anaerobic metabolism, with the result there is increased lactate in the tissue, resulting in lactic acidosis. Now, initially, the injury is reversible, that is, reversible hypoxic injury, ultimately resulting in irreversible hypoxic injury if the cause is not removed or inadequate treatment, and then it leads to death. So there is another flow chart. There is hypotension due to hypoperfusion leading to tissue hypoperfusion leading to cellular hypoxia, which results in reversible injury, and irreversible injury with persistent shock ultimately leads to end organ dysfunction and then death. Classification of shock: cardiogenic shock, hypovolemic shock, septic shock, neurogenic shock, and anaphylactic shock. These are the major types of shock. Now, we elaborate these types of shock. Hypovolemic shock: there is decreased cardiac output and decreased blood volume, and this occurs due to loss of blood, loss of fluids, which is due to vomiting, diarrhea, sweating, soft tissue injury, or intraperitoneal sequestration. Loss of plasma is seen in severe burns. Cardiogenic shock, there is failure of heart pump, which is due to heart damage or dearrangement of heart function. Septic shock, in which there is peripheral vasodilatation and pooling of blood resulting from immune response to bacterial or fungal infection. Examples are gram-negative endotoxemia, gram-positive septicemia, fungal sepsis, and superantigens. Neurogenic shock, loss of vascular tone, and there is peripheral pooling of blood. This is seen during accidents due to anesthesia or spinal cord injury. Anaphylactic shock, there is vasodilatation and increased vascular permeability. Now, hemorrhagic shock, again a flow chart. There is loss of blood due to trauma, accident, leads to decreased blood volume, which results in decreased cardiac output. CO is symbolized for cardiac output, and when the cardiac output is decreased, there is decreased blood pressure. So compensatory mechanisms come into play, like vasoconstriction, which leads to increased heart rate, leading to increased heart contractility and rise in blood pressure. So the blood pressure is maintained at normal levels. Again, the shock is reversible if all the compensatory mechanism, they maintain the blood pressure, but it becomes irreversible when these compensatory mechanisms fail. Now, cardiogenic shock, the important causes are myocardial infarction, ventricular rupture, arrhythmias, cardiac tamponade, which is due to fluid in the pericardial space, reducing the ventricular filling, leading to pulmonary edema, shock, and death. Then there is another cause of cardiogenic shock is pulmonary embolism. Now, pathophysiology of cardiogenic shock, flowchart. There is myocardial infarction. Now we follow it in the black boxes. There is myocardial ischemia or injury. There is systemic inflammatory response. There is increased nitric oxide synthesis. There is vasodilatation, and then compensatory vasoconstriction. On the other side, myocardial infarction leads to myocardial dysfunction, decreased stroke volume, hypotension, decreased coronary perfusion, cardiac and end organ damage, progressive myocardial dysfunction results, and there is death. At the same time, if there is compensatory vasoconstriction, that can also lead to cardiac and other end organ damage. Similarly, hypotension also leads to systemic hypoperfusion, and vasodilatation also leads to systemic hypoperfusion. They are marked with red arrows. Hypovolemic shock. Hypovolemic shock occurs due to rapid reduction in blood volume or plasma volume. Causes of hypovolemic shock: hemorrhage, severe dehydration, fluid loss resulting from trauma, severe vomiting, severe diarrhea, severe burns, then abdominal ascites, acute pancreatitis, diabetes mellitus, and overuse of diuretics. Now, hypovolemic shock, its pathophysiology, which is shown in flow chart. There is dehydration or hemorrhage resulting in reduction in intravascular blood volume, which leads to decreased preload, which again results in decreased stroke volume and cardiac output. This results in systemic hypoperfusion. So compensatory vasoconstriction takes place. There is severe tissue ischemia and hypoxia resulting in cellular and organ dysfunction. Now, septic shock. Sepsis is a clinical state that accompanies infection either confined to a local site from which toxins are absorbed or associated with the invasion of organisms into the bloodstream. Causes of septic shock: overwhelming microbial infections, endotoxic shock, that is gram-negative septicemia, gram-positive septicemia, fungal sepsis, and then superantigens. For example, toxins from the staphylococci lead to T-cell activation, thus induce systemic inflammatory cytokines response. Now, there are certain predisposing factors which are responsible to septic shock, and that include increased age, in which increased life support for high-risk patients, debilitating disease, increased use of invasive procedures, disseminated malignancy, increased number of immunocompromised hosts, secondary to malignancy, immunosuppression, and HIV infection. Now, in septic shock, the bacterial cell wall lipopolysaccharide, which is symbolized here as LPS, with lipid A core, and polysaccharide coat. Lipopolysaccharides and lipopolysaccharide binding proteins in the blood bind to CD14 molecules on leukocytes, endothelial cells, etc. And after binding to lipopolysaccharide, there are signals to a transduction protein called mammalian toll-like receptor protein 4, which is symbolized as TLR4. Signals from TLR4 activate vascular wall of cells, leukocytes, and cascade of cytokine mediators. Now, pathophysiology of septic shock in a flow chart: bacterial infection, endotoxin, that is lipopolysaccharide and other microbial products, binding of lipopolysaccharide protein in blood that binds to CD14 receptors on mononuclear cells. CD14 binds to toll-like receptor 4, and there is release of chemical mediators. Now, pathogenesis of septic shock in flowchart. There are microbial derived substances which are shown in yellow box, and then factor 8 and complement activation shown in light brown box. Now we follow the blue arrow. Complement activation, that is C3, is converted into C3A, and there is direct or indirect effect on the procoagulant and antifibrinolytic activity, resulting in microvascular thrombosis, leading to tissue ischemia, and then tissue ischemia leads to adrenal insufficiency, shown in the last box in brown color and pointed by black arrow. Then we follow that these microbial derived substances leads to endothelial activation, resulting in release of interleukin 6, interleukin 8, nitric oxide, reactive oxygen species, and platelet activating factor, which all lead to vasodilatation, increased permeability, decreased tissue perfusion, all this shown by black arrow, and ultimately multi-organ failure. And multi-organ failure is the end result. On the other hand, again we follow microbial derived substances leads to neutrophil and monocyte activation. Now we follow the green arrow. There is soluble tumor necrosis factor, interleukin 1 and HMBG1 release, and then interleukin 10, and then tumor necrosis factor receptor and apoptosis, leading to immunosuppression. Now this flow chart is taken from your textbook Robbins 10th edition, and you can consult it further. Now there is another simplified chart of septic shock showing the pathophysiology. Lipopolysaccharides leads to release of tumor necrosis factor that leads to production of interleukin 1 that is responsible for the production of interleukin 6 and interleukin 8, and then nitric oxide is produced and platelet activating factor. Ultimately, they act on monocytes, macrophages, neutrophil, and there is endothelial cell activation, and then complement activation, which is C3A and C5A, resulting in local inflammation. Then if they are produced in moderate quantities, then there is fever or there is release of acute phase reactants, and then they act on the bone marrow to produce leukocytes. These are the systemic effects, and when high quantities are produced, then there is low cardiac output, low peripheral resistance, blood vessel injury, thrombosis, DIC, ARDS, and then septic shock. Now there is toxic shock syndrome. Toxic shock syndrome is a potentially fatal illness caused by bacterial toxins, that is superantigens, released by Staphylococcus aureus and Streptococcus pyogenes. Superantigens are polyclonal T lymphocyte activators that induce systemic inflammatory cytokine cascade similar to that occur in response to lipopolysaccharides. This action can result in a variety of clinical manifestations ranging from a diffuse rash to vasodilatation, hypotension, and shock. Neurogenic shock. Neurogenic shock occurs in the setting of anesthetic, accident, or spinal cord injury, causing loss of vascular tone and peripheral pooling of blood. Anaphylactic shock. Anaphylactic shock is a decrease of systemic vascular resistance, primarily due to massive histamine release from mast cells after activation of IgE mediated hypersensitivity reaction, as well as increase synthesis of prostaglandins. This leads to vasodilatation and increase vascular permeability. Ultimate results are systemic hypotension, tissue hypoperfusion, and cellular anoxia. Causes of anaphylactic shock may be drugs, accidental exposure to allergens, along with coexisting respiratory complaints such as wheezing and dyspnea. Systemic inflammatory response in anaphylactic shock is respiratory distress, wheezing, urticaria, and angioedema. Stages of shock: non-progressive phase, progressive phase, and irreversible phase. In non-progressive phase, reflex mechanisms are activated and perfusion is maintained with the help of baroreceptors, reflex mechanism, release of catecholamines, activation of renin-angiotensin axis, release of antidiuretic hormone, and generalized sympathetic activation. The net effects of these mechanisms are tachycardia, peripheral vasoconstriction, renal conservation of fluids, resulting in restoration of circulation and tissue perfusion. Progressive phase, tissue hypoperfusion starts and metabolic imbalance takes place. Persistent oxygen deficiency leads to intracellular anaerobic glycolysis with lactic acidosis, which reduce tissue pH and vasomotor response. This results in reduced cardiac output and anoxic injury to endothelial cells, which leads to DIC, that is disseminated intravascular coagulation. Now, irreversible phase, when there is failure to restore circulation either by compensatory mechanism or by therapeutic intervention, the process of shock enters the irreversible state. Severe cellular hypoxia and tissue injury takes place. Lysosomal enzymes leak further aggravates the shock. There is reduced myocardial contractility, renal shutdown due to acute tubular necrosis, and ultimately the outcome is fatal, that is death. Now, non-progressive shock is represented in bar diagrams, that is initial shock. Pathogenesis is activation of baroreceptors, catecholamine release, renin-angiotensin activation, release of ADH, and sympathetic stimulation. The effects are peripheral vasoconstriction, cool, clammy skin, tachycardia, fluid conservation by kidney. Another bar diagram showing progressive shock in which the pathogenesis is ARDS, then anaerobic glycolysis, lactic acidosis, low tissue pH, impaired vasomotor response. The effects are decreased cardiac output, DIC, mental confusion, decreased urinary output. Then another bar diagram showing irreversible shock in which the pathogenesis is persistent vasoconstriction, vasodilatation, and vascular permeability, myocardial ischemia, cerebral ischemia. Then there is release of tumor necrosis factor, then there are intestinal factor, bacterial factors, and there is hypercoagulability, all come into play. The effects are in brain, there is necrosis and death, lungs, ARDS, heart, focal myocardial necrosis, kidney, acute tubular necrosis, liver necrosis, spleen hyperplasia, stomach ulcers, intestine necrosis. Morphology of shock. Initially we discuss the salient features and then we'll elaborate them. Since shock is characterized by failure of multi-organ systems, The cellular changes may appear in any tissue. In brain, there is ischemic encephalopathy, heart coagulative necrosis, subendocardial hemorrhage, contraction band necrosis, kidney, acute tubular necrosis, lungs, diffuse alveolar damage develop, which is called shock lung, gastrointestinal tract, hemorrhagic enteropathy, adrenal glands, cortical cell lipid depletion may occur, liver fatty change, central hemorrhagic necrosis. Now, as we know that morphological changes in shock are due to hypoxia, resulting in degeneration and necrosis in various organs. Hypoxic encephalopathy, neurons more prone to hypoxic damage. Cytoplasm of affected neurons becomes intensely eosinophilic and the nucleus is pycnotic. Dead and dying brain cells are replaced by gliosis. Heart is more vulnerable to the effect of hypoxia than any other organ. Subepicardial and subendocardial regions show hemorrhage and necrosis. Zonal lesions and distortion of myofilaments may be seen. Lungs. Because of dual blood supply, lungs are not generally affected by hypovolemic shock. In septic shock, lungs may manifest with ARDS or show various other features like diffuse alveolar damage, interstitial lymphocytic infiltrate and edema, formation of alveolar hyaline membrane and thickening, along with fibrosis of alveolar septi, presence of microthrombi in pulmonary vasculature. Kidney shock may lead to irreversible renal injury resulting in anuria and death. Kidney is swollen and may show acute tubular necrosis and brown tubular casts. The latter are seen in case of extensive muscle damage due to intravascular hemolysis. Adrenals, stress response in shock, release aldosterone, glucocorticoids, and catecholamines. Active adrenal cell utilize stored lipid for the synthesis of steroids. Adrenal hemorrhage may be seen in severe shock. Hemorrhage gastropathy. There are multifocal superficial ulcers. Adjoining bowel mucosa is oedematous and hemorrhagic. Microscopy reveals mucosal and mural infarction. Then changes in liver. Liver is usually enlarged and show a mottled cut surface. Section show focal necrosis and fatty changes. Now, dear students, I have discussed the subject of shock with you. If you find any difficulty or any question, please write in the comment box and inshallah I'll answer it.